Hello, my name is Kelly Martin. Pneumonia is a common condition diagnosed and treated in the primary care setting, especially during the winter months. Chest radiography is the gold standard in diagnosing pneumonia. As nurse practitioners, we may work in facilities without radiology and need to diagnose pneumonia based on a patient's history and physical examination. During my research, I learned there's a need for more research on diagnosing pneumonia based on physical examination due to the variations in studies of clinical findings and its correlation to pneumonia, along with the variations in assessment skills between providers. A solution to this is holding a in-service on respiratory assessment and interpretation of findings for providers at facilities without radiology. Now I'm going to perform a respiratory assessment focusing on the parts that are linked highly to pneumonia. First, I'm going to inspect the anterior thorax. I'm going to be looking at shape and configuration. Next, I will assess respirations, looking at the rate, rhythm, depth, character, and ease of respirations. Several studies found a correlation between tachypnea and pneumonia, especially in children. Next, I would palpate for tenderness and masses, then assess for tactile fremitus, asking the patient to say 99.
99, 99, 99, 99, 99, 99.
Increased fremitus or vibrations may indicate consolidation or pneumonia. Next, I will auscultate breath sounds, asking the patient to take a deep breath when my stethoscope touches his chest. And I would go on down using the ladder technique. And you should hear bronchovesicular in the first and second intercostal spaces and then vesicular throughout. If you would hear bronchial or bronchial-vesicular throughout the remainder of the lung fields, this may indicate pneumonia. You're also going to be listening for adventitious or added breath sounds. Crackles or rails is a strong indication for pneumonia. Also, there has been some link between wheezes and pneumonia on some of the studies from my research. Next, I will assess the posterior thorax, again palpating for tenderness and masses. Next, I will assess chest expansion around the 10th rib. I have the patient breathe out, and the chest should expand equally. Unequal expansion may indicate pneumonia. Next, I will assess for tactile fremitus just like I did on the front, and then I would percuss for dullness. Dullness is a strong indication of consolidation or mass, possibly pneumonia. You're going to make sure to percuss in between the ribs. So then you will use the ladder form and go on down just like we would have with the tactile fremitus. Next, I will do the percussion for diaphragmatic excursion, which I'm going to skip over so I have time to do the transmitted voice sounds. Next, I will auscultate the breath sounds on the back, listening for the same things I did on the front. Finally, I'm going to perform the transmitted voice sounds, which have a strong correlation with pneumonia. First, I will assess bronchophony, asking the patient to sing 99 as my stethoscope touches his back.
99, 99, 99, 99.
And you should hear a muffled, indistinct 99. If you hear a loud, distinct sound, that may indicate pneumonia. Next, I will assess egophony, asking the patient to say E.
E, 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 E.
Again, you should hear a muffled, long E sound. If you hear a long A sound, that may indicate pneumonia. Next, I will assess whispered pectoriloquy, which I will be asking the patient to whisper 99 or 1, 2, 3. In this case, I'm going to use 1, 2, 3. And you should hear a faint whispered voice, and it should be indistinct or nothing at all. If you hear a loud, clear whisper sound, that may indicate pneumonia. And this completes my exam.